How do you confidently navigate a posterior Bankart repair when anterior Bankart repairs get all the clinical spotlight? Posterior labral tears disrupt the shoulder joint's static stabilizers in up to 12% of cases. Mastering this minimally invasive surgical technique is essential in restoring the shoulder's stability. Welcome to SportsMed Snapshots. I'm Eloise, an undergraduate student at Dalhousie University, and in this short video, I'll be showing you a posterior Bankart repair. A posterior Bankart repair involves reattaching the torn posterior-inferior capsulolabral complex to the glenoid rim after a traumatic injury to the shoulder. Unlike standard anterior repairs, this technique is used for those with subsequent posterior instability requiring an inverted approach to the repair. To start, the patient is positioned in the lateral decubitus position with a 30-degree posterior tilt and the arm under traction. The posterior portal is established 10 mm inferior and medial to the posterolateral corner of the acromion. This provides a precise 45-degree approach vector to the posterior glenoid rim. Next, an anterior-inferior primary working portal is marked 5 mm lateral from the coracoid process. To ensure accurate trajectory into the glenohumeral joint, ensuring an entry that's parallel to the glenoid, an outside-in technique is used with an 18-gauge spinal needle. An anterior-superior viewing portal is then marked 20 mm lateral and 10 mm superior to the coracoid process using an inside-out technique through the rotator interval. To better visualize the extent of the tear, we switch our viewing perspective to the anterior superior portal. An arthroscopic tissue liberator is then used to fully elevate the labrum off the glenoid neck. The surgeon must pay close attention in achieving complete tissue mobilization. Inadequate tissue release is a critical pitfall that prevents the capsulolabral complex from reaching the glenoid face for a tension-free repair. Once the labrum is well mobilized, a burr is used along the neck of the glenoid to remove the calcified layer, creating a bleeding bone to facilitate improved healing. The drill guide for the suture anchor is then introduced through the inferior cannula and positioned onto the face of the glenoid, as close to the 6 o'clock position as possible. 3 suture anchors are drilled into the glenoid face, 45 degrees relative to the glenoid rim and at least 3 mm inside the edge of the glenoid surface. Finally, the capsule is taken and fixated onto the glenoid using a circumferential suture tie to reduce joint volume. This is then secured with 3/0 knots using a simple suture configuration. This step is repeated with additional anchors, moving superior from the 6 o'clock position, placing anchors about 10 mm apart until the labrum has been completely repaired back onto the glenoid rim. Thanks for watching.